Hi everyone, in this video I'll be discussing TB treatment guidelines. So TB treatment guidelines, the program what we have in India currently is called National TB Elimination Program. So under this program, the TB has to be treated only after testing the culture and sensitivity. So you should know whether the drug works or not. So you have to check the drug sensitivity. Now, if all the first line drugs are working, so then we call it as drug sensitive TB, mainly the H and R. So if there is no resistant problem, we consider as drug sensitive tuberculosis. There is no category like category 1, category 2. Now it is considered as drug sensitive TB. Now in drug sensitive TB, you have to give the intensive phase, and one more is called continuous phase. Now in intensive phase, the duration is 2 months and continuous phase is for 4 months. And remember, these drugs are given as fixed dose combination. These are given as FDC. FDC means a single tablet contains all the 4 drugs. Depending on the weight of the patient, we give 1 tablet, 2 tablet, 3 tablet like that. So a single drug contains all the 4 drugs. Now this is given daily. Remember, these are given daily. Earlier it was given thrice weekly. So now the regimen is every day. So a single tablet contains all the 4 drugs. That's why it is called fixed dose combination. And the duration is 2 months and this is 4 months. So total duration for drug sensitive TB is 6 months. So the total duration is 6 months. Now the problem is the TB bacilli is becoming resistant day by day. That is a major issue what we are dealing with, and that is called drug resistant TB. So DRTB stands for drug resistant TB. Now mainly we can see a resistant to H stands for isoniazid. If there is only resistant to H resistant TB, then what is the treatment for that? You give the remaining drugs, the R, Z and E. So along with that you add a fluoroquinolone, and that is levofloxacin. And these has to be given for totally 6 months. So 4 drugs has to be given for 6 months. There you saw intensive and continuous phase. Here you have to give them continuously for 6 months. Now once you know the H resistance, it is important that we know the second important thing, that is called rifampicin resistant TB. Rifampicin resistant TB. In the future we'll write it as RRTB or an MDR-TB. So they can ask in the exam, what do you understand by MDR-TB? MDR stands for the resistant to both H and R resistance. So if the TB bacilli is resistant to first H and R, it is called MDR-TB. Now the third important problem what we are facing is, nowadays there is a definition of pre-XDR TB. Now pre-XDR TB, what is the continuation of the definition? Same MDR TB. So along with MDR TB, patient will have one more problem. He will have any one fluoroquinolone resistance. So any one fluoroquinolone resistance like moxifloxacin, levofloxacin, there is a resistance. The fourth drug resistant TB we need to deal is extensively drug resistant TB. XDR means extensively drug resistant TB. Here the definition remains same. MDR TB. Along with that, any one fluoroquinolone resistance. Now along with that, they have added one more. Any resistance to group A drugs. Group A drugs. So what are the group A drugs? Commonly, the resistance may be to bedaquiline or for linezolid. So bedaquiline or linezolid, or for both, then we call it as XDR tuberculosis. So previously XDR-TB was like MDR plus 1 fluoroquinolone plus 1 second line injectable. That is not their definition now. So let me repeat this. H resistance means only isoniazid. Rifampicin and MDR-TB, there is H and R resistance. Pre-XDR means MDR-TB, same thing, plus 1 fluoroquinolone. XDR means same, along with that resistance to group 1 drugs. Sir, what are the group A drugs you mean by? So there is a classification of group of drugs. I'll tell you what is the importance of that. So we have group A, group B, group C, depending on their effect. So levofloxacin, the fluoroquinolones, bedaquiline, linezolid, they are group A. So they have to be used commonly. Clofazamine, cycloserine, group B. Group C are ethambutol, delamanid, pyrazinamide, imipenem, meropenem, amikacin, streptomycin, ethionamide, prothionamide, and PS. Now, how do we use them? When do you use them? We'll come to that. So, any resistance to them, along with the MDR-TB and 1 fluoroquinolone, we consider them as XDR-TB. Okay. So, we understood the meaning of the resistant TB, and we know how to manage S-resistant TB. We know how to manage H-resistant TB. Let us manage the multi-drug resistant TB. To manage multi-drug resistant TB, we have 3 important regimens. So we have 3 important regimens proposed. What are those? Number 1, a shorter regimen and a longer regimen, and a regimen called BPAL. A regimen called BPAL. Let us understand one by one. So this is the one, shorter regimen, longer regimen, and the BPAL regimen for MDR-TB. Let us start the first one. The first one is the shorter regimen for MDR-TB. Shorter regimen. Now in shorter regimen, all the drugs given are oral drugs. All are oral drugs. Point number 1. Now the injections are not acceptable and they are not used. In shorter regimen, there are certain criteria. When do you use it? What are the criteria to start this? Criteria are patient should have the bacilli which is sensitive to fluoroquinolones. So the bacilli should be sensitive to fluoroquinolone. Patient should not be exposed to second line drugs. So you should not have been exposed to second line drugs, or you would have exposed to less than 1 month. The third important thing is the disease should not be severe. So it should not be severe extrapulmonary TB. So the disease should not be severe. It should be less severe, and the TB should not be extensive, not an extensive TB. The disease should be not extensive. Then it should not be used not in pregnant and lactation. So this regimen is not preferred in these patients. Not in severe extrapulmonary, not in extensive TB, not in pregnancy, and not in children less than 5 years. So in them, don't use this regimen. Severe extrapulmonary, extensive TB, pregnancy, lactation, child less than 5 years, or you can use them in patients who are sensitive to fluoroquinolone. They are not exposed to second line. Even though they are exposed, it should be less than 1 month. So where you should not use, these are the criteria where you should not use them. Not for these cases. Now the shorter regimen, as the name suggests to us, the regimen should be shorter. How many months? The regimen is for 9 months. So does it have intensive phase and continuous phase? Yes, it has an intensive phase and a continuous phase. Now in intensive phase, what is the duration, sir? The duration is 4 months. So what is the duration for continuous phase? Minus it, you will get 5 months. Now many times this intensive phase can be extended up to 6 months if the patient is still positive for TB bacilli. Now what is the regimen for this, sir? What is the regimen? Now in this regimen, the major drug we use is bedaquiline. So when you are using bedaquiline, keep a point that it should not be used for more than 6 months. So it should be restricted only for 6-month use only. So since there is resistance to rifampicin, we don't use it. We use the remaining drugs, H, Z, E drugs. Sir, you told MDR TB means H resistance also. Now what we do is, here the H what we use, isoniazid, we use it at high dose. So the high dose can overcome the resistance, so we can use it. So we have given bedaquiline, H, Z, E, 4 drugs. Sir, is there anything to add here? Yes, for this we add levofloxacin. Then we add a drug called clofazimine, a anti-leprosy drug, and also ethionamide. Also, ethionamide is added. So totally around 7 drugs: bedaquiline, isoniazid IZ dose, pyrazinamide, ethambutol, levofloxacin, clofazimine, ethionamide. Now what we do in the continuous phase, we will remove the first drug. What is the first drug? This one. And we will remove the last drug, this one. Bedaquiline, I told you it's only for 6 months. So what is remaining now is the Z and E. Along with that, the levofloxacin and clofazimine, the 4 drugs are used for remaining period. The remaining drugs are used. So remember, the criteria is very, very important. It's not used for so much severe disease or extensive disease, not for pregnant children, but only you can use it if the patient is still sensitive to fluoroquinolone and he is not exposed to second-line drugs. Yes, but if the patient is having severe disease, pregnancy, and all those things, then we have to give a longer regimen. Okay, so we understood the drugs used in shorter regimen for MDR TB. The second one, what we are going to understand is a regimen, the longer regimen. Now, longer regimen is preferred if the TB is extensive, if there is severe extrapulmonary tuberculosis in pregnant children. So then we have to give a longer regimen. Longer regimen usually takes around 18 to 20 months. It takes around 18 to 20 months. The treatment, that's the reason it is called longer. You can compare the shorter, it was 9 months, it is 18 to 20 months. Here we have an intensive phase and a continuous phase. Here the intensive phase lasts for 6 months and continuous phase lasts for 12 months. So totally you will have 18 months. Now you may ask a question, sir, how many drugs should I use in intensive phase? Minimum. So minimum it should be 4 drugs in intensive phase. And in continuous phase, minimum it should be 3 drugs. You may ask a question, sir, how do I know which drug should I use? How do I know which drug should I use? Now, to understand what drug should I use, I told you we have a group of drugs. They have a grouping of drugs. See, the second line TB drugs are grouped as ABC, I have told you already. If you want to treat an MDR TB, so you can choose from the first group. So these are the first 3 drugs. You can include all of them first. So you can include the first 4 drugs to treat TB. So include all the 3 medication unless they cannot be used. If there is resistance, then only. If there is resistance, you can include the next drug from here or here. So it's a preference like this. Now suppose, what is XDR TB? What is the meaning of XDR TB? Can you tell me what is the meaning of XDR TB? Yes, the MDR TB plus 1 fluoroquinolone plus bedaquiline or linezolid. Suppose a patient has resistance to bedaquiline, or he has resistance to linezolid also and fluoroquinolone also, then it is called XDR TB. Then what to do with XDR TB? For XDR TB also, we use a longer regimen. But in longer regimen, instead of these drugs, the remaining drugs are going to be used. That means in intensive phase, 4 drugs minimum, continuous phase, 3 drugs minimum. So for managing XDR TB also, we use this longer regimen. Clear? Yes. So remember, if the patient is having MDR TB, you want to use longer regimen, use the first 4 drugs. And depending on the sensitivity and culture and sensitivity, then we prefer other drugs. You can see the second line here. Add 1 or both medications. The last one you read, add to complete a 4 to 5 drug regimen when medicines from group A and B cannot be used. When you cannot use group A drugs in XDR TB, then you can use these medications. That is how we manage XDR-TB, and also the MDR-TB with longer regimen. Intensive phase minimum 4 drugs, continuous phase minimum 3 drugs, the duration 6 to 12 months. That is how we manage MDR-TB, that is longer regimen. So the same regimen can be applied for XDR-TB also. Yes. Moving on to the third regimen, it is called the BPAL regimen. BPAL regimen, there should be some criteria to use it. Now we use it for managing MDR-TB as well as rifampicin-resistant TB, not for XDR, it is for MDR-TB. Now MDR-TB, the criteria to use this BPAL regimen means patient should be showing fluoroquine resistance. So there should be fluoroquinolone resistance. That is one criteria. Second, he should not be exposed to, no exposure to the bedaquiline or the linezolid. Or even if they are exposed, it should be less than 1 month. Less than 1 month exposure to these two drugs. Then they are the criteria to start BPAL regimen. Now in BPAL regimen, the name stands for P for bedaquiline. Remember, bedaquiline you should use only for 6 months. Now P stands for pretomanid and L stands for linezolid. L stands for linezolid. Now in this BPAL there is no intensive phase or continuous phase. It is given for 6 to 9 months. The duration of BPAL is 6 to 9 months, but in that bedaquiline should be used for only 6 months. So these are the regimens for MDR-TB, the shorter regimen, then the longer regimen which can also be used for XDR-TB, and the BPAL regimen. I told you the criteria for that. The last one that has been updated in National TB Elimination Program is the TB prophylaxis. Now, why should we give TB prophylaxis? The reason is there are people who are immunocompromised, like HIV. There is a risk they get TB. Second, the close contacts. If they are living in a small room, 4 or 5 people are there. If somebody coughs, they will also get. So, the prophylaxis regimen has also changed. How it has changed? Suppose there is exposure to drug-sensitive TB. So, drug-sensitive TB, exposure is there. Then the prophylaxis can be given with the drug called isoniazid. So 6 months of INH can be used. Now this is preferred in HIV positive patients. HIV positive patient, this is preferred. Or there is one more regimen where we use 3 months of H and R. H stands for INH and R stands for a drug called rifampicin. The name is called rifampicin. So we are using it here. The reason why rifampicin is not used in HIV positive patient because it is having enzyme induction property. And compared to the rifampicin, the enzyme induction property is medium. So since it's an enzyme inducer, there is a chance of drug interactions with HIV drugs. So that's why we avoid in patients who have HIV positive. Otherwise, other patients who are close contact, immunocompromised, then we can go with 3HR. So that is if the patient is exposed to drug-sensitive TB patients. The next one is if the patient is exposed to drug-resistant TB, then what to do? Drug-resistant TB if he is exposed. Now if in the culture and sensitivity the patient has shown to have H-sensitive, so TB is H-sensitive, then you can give the prophylaxis with isoniazid for 6 months. 6 stands for the months and you can give isoniazid if he is H-sensitive. If the patient is rifampicin sensitive in drug-resistant TB exposure, then you have to give rifampicin for 4 months. It is for 4 months. Now, if the patient is exposed to MDR-TB patient, what is MDR-TB? Is resistant to both H and R. So H and R resistance, then you cannot give H or R. Then what to do? Now we have to give 6 months of levofloxacin. So 6 months of levofloxacin has to be given. So these are the regimens what has changed in the recent National TB Elimination Program 2021. That is the updated versions for it. So thank you all. Thank you.